to another video. ICU training video. This time is heart failure. Again, for those who are new to this channel, my name is Manny Barbosa. I am an ICU nurse educator and my background is ICU for 30 years, and I'm still working at the bedside. So I'm applying what I'm teaching. I'm learning every day. Every day is always something new. You learn a lot from. You either learn a lot or question a lot. I have seen some changes at the bedside nowadays because I used to work with a lot of seasoned intensivists, so now I'm seeing more new doctors, and there's this thing about new orders. You've been there, done that kind of thing, and the tendency is that's why I said you ask more. Why are you ordering this way? Why? Help me understand. Why did you order this? Because this is something that supposed to be for this, So ICU nurse is another layer of protection. So you are another set of eyes and brain to double check, right? So you practice asking questions to your intensivist or nurse practitioner or whoever you're working with. So today is a heart failure, and we're going to discuss the definition of heart failure, pathophysiology of heart failure, signs and symptoms, and nursing management. Over the years, who tend to get really frustrated are the heart failure doctors. The doctors, because when they look at the MAR, the nurses held the medication, and the patient condition will get worse, right? Because there is that negative feedback loop. So over the years, we know that if the blood pressure, we don't give beta blockers, we don't give those metoprolol, ACE inhibitors, digoxin, even Lasix, But the main problem really for heart failure is low cardiac output, because the heart itself is failing, right? So then don't blame the nurses. We're just following orders. However, the more that we understand the pathophysiology and the disease process, the more that you will calling the doctor more often, especially if they don't rewrite their medication or their orders. I think there should be a sets of medication orders for heart failure that includes the right verbiage, because automatically, if I'm following the doctor's order, hold, don't give, if the blood pressure below, things like that. And we all know that their blood pressure is going to be really low. And if you don't give the medication, the more it's gonna get worse, right? Their CHF, their congestion. So that's something that I want you guys to understand as ICU nurses. And then signs and symptoms, nursing management. So heart failure is a failure of the heart to do the normal function. So what is the normal function of the heart? Anyway, is contract, squeeze blood out, right? And relax, supposed to be. So you'll get the time. The heart will get that time to refill. So the inability of the heart to eject. So there's that problem. An adequate cardiac output. So cardiac output, it has always been what we're looking for in terms of hemodynamics, right? To meet the oxygen and metabolic requirements of the body. So if I'm going to ask you, what is that requirements of the body? How do you measure that? Some hospitals are basing it by checking SVO2, right? And some hospitals are checking the oxygen consumption, like FIC, cardiac output, wherein they will use an arterial oxygenation minus venous oxygen consumption, and that's how they find out how much of a cardiac output. And so this can be confusing again to some. I'm hoping that in this video I can give you some insight. So this is your heart, the review of anatomy and physiology. As we all know, that blood coming from, hopefully you know this, guys. Let me get my pen. So blood coming from the inferior vena cava and superior vena cava will dump into the right atrium, right? So when you connect this patient to our hemodynamic monitoring, especially how do you know their fluid status? So the doctor will normally put central line, and then they ask you, can you connect that central line to a CBP monitoring? Then go ahead. Or better yet, if they really would like to manage the fluid status of the patient, again, they will float a PA, pulmonary artery catheter, right? It can be done in the OR, or it can be done at the bedside. So let's say it's your PA catheter. So you will assist the doctor, and I'm hoping that by now you know I've provided a video on how they float PA catheters in my channel, so if you guys want to check that out. And also, it's better that you have experience in assisting the doctor, because once they give you the other part of the catheter, the PA catheter, then you consider that as non-sterile and you manage that, like balloon up, balloon down, flushing all the ports, right? You connect your pressure bags, 300 millimeters of mercury pressure, and then you connect the cables and the monitor, and you're able to open your monitor for PA insertion. And then wedge, when you wedge, or occlusion, pulmonary artery occlusive pressure. So then balloon up, it will go down to the tricuspid valve, right? So we're talking about blood now, right? Atrium, blood will flow into the right ventricle, and then it goes to the pulmonary artery, passing the pulmonic valve here. And then there is a little bit higher pressure here now. It goes to the lungs for oxygenation. And then after that, it will go to the pulmonary vein. The oxygenated blood will go to pulmonary vein. So there is that 100% oxygenated blood, depending on if they have a good hemoglobin level or hematocrit, this kind of things. But hopefully they are. And it gives you that 100% saturated blood, oxygen saturated blood, right? However, you have to remember physiologic shunt. This 100% will not gonna go back to the left atria 100%. It will come back like 95%. I don't know if you know, but if you know, let's review it again. There is that physiologic shunt. If I asked some of the nurses in the class, it looks like majority don't know or don't remember. Physiologic shunt is a mixing of venous unoxygenated blood with oxygenated blood. So where are those blood? Where is that blood came from? So the question is, where? So if you remember that in the when the blood comes out, oxygenated blood comes out, there is what we call bronchial artery, right? So the bronchial artery will feed the bronchial tree, circulate blood into the bronchial tree, right? And in the bronchial tree, once that blood is used, it will drain back into the pulmonary vein. So that blood is unoxygenated. It get mixed in with the oxygenated blood. So that's why there's a drop of that saturation. Okay, so that's one source of your physiologic shunt. Blood from the bronchial tree. The the other source of physiologic shunt is the coronary arteries. Okay, there is a coronary artery here, right? This is our coronary arteries. Will feed the blood would supply blood into the myocardium of the heart so that it will contract, relax, contract, healthy heart. Once the blood is now consumed, and it will drain back into the coronary sinus via the division vein, right? The division vein. And that is another unoxygenated blood that get mixed in the ventricle. So therefore, that's the two sources of physiologic shunt. And then of course the third source will be during pregnancy, when the fetus inside the womb don't use their respiratory system, they don't breathe, so there is the coarctation of the aorta, or the what we call tetralogy of flow, right, where the atria will have a shunt into the right atria to the right left atria, and then goes out, right? So but since we are in an adult ICU, so physiologic shunt is from the bronchial tree and from the coronary sinus. Okay, so now it comes out. Blood comes out to the pulmonary aortic valve here, into the aorta, and into the system, wherein we're continuously producing carbon dioxide. So outside the system is what we call systemic vascular resistance, depending on the pipes, like your arterioles, right? So the arterioles are responsible for constriction. So let's just say this is your aorta, and it goes into the peripheral capillaries. There's a capillary here, and there's your arterioles here. So they have an alpha 1, right? So alpha 1, and then into the capillaries, and then they go to the venules, to the vein, and then they go back. Of course, you have like for the brain, for the lungs, for the brain, for the heart, kidney, splenic, which is your GI, liver, spleen, and then you have your musculoskeletal and skin. So what happened here is your mean arterial pressure is the one who helps to distribute, right? So mean arterial pressure, normally we want it above 65, and then it will feed and supply the blood into different organs, and after that it will absorb the carbon dioxide, and then it get carried and transported back into the heart, to the right atrium, and then into the lungs. Okay, so that's just a review. So this is what I was referring to. So these are your arterioles here. Okay, they are very sensitive, so they are guarding your body in terms of, if they sense a low cardiac output, they will constrict, they will react, they have an auto-regulation. And once they pass that, there is what we call the 25 millimeters of mercury pressure that the left ventricle needs to work, right? So the higher the pressure, the harder for the ventricle to eject blood. Okay, so that's what happened. And then the kidneys are very, very sensitive, so we like to have at least a good MAP, mean arterial pressure per perfusion, for your kidney, or else you're going to end up having an acute tubular necrosis. Okay, so the definition, as I've mentioned, is inability of the heart to eject an adequate cardiac output. But why? Why is it? Well, some patient with coronary atherosclerosis, valvular heart disease, hypertension, cardiomyopathy. So pretty much you're referring it to the engine. So the heart is failing because of all these problems. Okay. I want you guys to understand that heart failure is classified into many subtypes. I mean, I've learned it in nursing school and I've seen it at the bedside. Sometimes we have patient with high flow, high, high out cardiac output. So if you have those high output, high cardiac output heart failure, meaning I don't have a problem with my cardiac output, you can have 4 to 8 liters. However, there are conditions out there that really makes your body to be hyper metabolic state, wherein they're needing so much blood, and even if you have already 4 liters or 5 liters, it's still not enough. So probably because what happened is that there are conditions like thyroidoxicosis. Okay, the thyroidoxicosis, it can actually ask for more, probably 20 liters demand, and you can only supply 4 to 8 liters, so that's not enough, right? So you are unable to give the demand into the tissue, so the tissue are starving, and that is considered heart failure. Or if you have a severe anemia, so again, what are those? Thyroidoxicosis, right? So this is too much hypermetabolism. And then severe, they call it very, very severe anemia or just severe anemia. So if your hemoglobin is like 5, probably that's not good, right? Because if you have 3 grams of hemoglobin in your body, then there is that decrease in oxygen carrying capacity, because we know that hemoglobin binds with oxygen, right? With the use of ferrous sulfate, not ferritin. So the heme and the globin, right? So and then of course that will help in tissue perfusion. Pregnancy. So if they're pregnant, some pregnant mother will tend to develop what we call high cardiac output heart failure, or high output heart failure. And some, because imagine you have there's a fetus that's gonna ask, that will share with the mother in terms of blood supply, so your heart needs to make up for that. Then I don't know how to pronounce this, Paget or Paget disease, right? Paget or Paget disease. Sorry guys. So it's another high output heart failure. So there is that our bone, or a patient with Paget disease has this, there is that high bone turnover, wherein they do a anabolic or catabolic. There is that rapid anabolic or catabolic metabolism. So there is that usually they're asking for more blood supply there. And beriberi, like vitamin thiamine deficiency, right? Beriberi. So that thiamine deficiency is another problem. They tend to have a peripheral dilation. So if you're dilated, you need more blood. And another cause also is AV shunt. Okay, so if you have some patient with AV shunt, like an injury to the arterial to the arteries, and then they will shunt it. So that's what we call an arteriovenous shunting. All right, and what happened here? It's still considered as heart failure, although the cardiac output is not an issue. It was just not enough. The other one is the low output. So the low output the low output heart failure. Sorry guys, my pen is just acting out. Low output heart failure. Low output heart failure. This is what we all know, right? That your cardiac output is not good enough. When we think about your heart failure, guys, let's review also what we call Laplace. Sorry guys, let me just grab my pen here. So the Laplace Laplace law, Laplace law, right, is actually telling us that pressure is equal to tension divided by radius. It is directly proportional with tension but inversely proportional with radius. So which means if I have three fingers here and I will squeeze it, I can squeeze it really hard, right? There's a strong grip there. However, if you're gonna let me squeeze the whole heart, it's not as strong as when it's only squeezing three fingers. So that is the Laplace law, which gives us an idea that if the heart is dilated, you will expect that the inlet radius is bigger than the regular heart, and that will decrease the tension, right, and decrease the pressure. So decrease the tension and decrease the pressure for the left ventricle to contract and eject blood. Okay, so that is your Laplace law. All right, and so sometimes the pathophysiology is, I want you guys to understand also that if you're continuously dilating your ventricle, eventually what's going to happen is there will be a increased volume, right? So there will be an increased volume, or it will volume overload, okay. However, it will then decrease the pressure. So there will be an incident where myocardial insult and excessive load is the initial event that weakens the heart to contract. So if that happened, you are now looking at impairment of the left ventricle function. So the ventricle becomes pathologically dilated because of that. So becomes pathologically dilated. And if that happens, then you will decrease cardiac output, right? So be very careful. If your body senses that you have a decreased cardiac output, something will happen during this process. Either your body will sense it that, hey, I have a decreased renal blood flow. So it will trigger a release of renin, right? Your renin, angiotensin, aldosterone system. And so that angiotensin 1 will convert into angiotensin 2. That is a very potent vasoconstrictor. And then your aldosterone and renin and we're just gonna hold fluids, right? So that they're sensing a low cardiac output. And that's not good. So eventually when we discuss phase 3, that really could cause a negative feedback loop. Okay? So therefore, this increased neurohormones. So what are these neurohormones? So the neurohormones are typically your your what we call the I call it the not angiotensin, but it's the adrenergic nervous system. Okay, so Neurohormones are your adrenergic. So when you say adrenergic, okay, adrenergic nervous system are stimulating your baroreceptor to signal sympathetic nervous, stimulation that could cause to stimulate the beta 1. Alright, so adrenergic stimulates your SNS, sympathetic nervous system, and then it will stimulate your beta 1, so it increase your heart rate to compensate for low cardiac output, and then it will increase contractility, right? So it's good, but it's not good because your heart cannot do all this now. I mean, I'm sick. Why do you want me to work harder? I'm sick. Why do you want me to contract stronger or harder, right? And then, of course, in that case, it will increase afterload because your SVR, systemic vascular resistance, right, as a compensatory mechanism. Because if they feel like you have a low cardiac output, as I mentioned, the peripheral arterioles will sense as an autoregulation. They will constrict. That will increase your SVR. So what you see, dyspnea, backflow, pulmonary edema, backflow, PND, backflow, JBD, backflow, angina, peripheral edema, weight gain, pale skin, oliguria, and fatigue. So you'll see this in the later or towards the end. So again, this is the compensatory mechanism of heart failure that we don't want. It has a good intention, but it has a bad outcome, right? So we call that negative feedback loop. Before I'm gonna go here, or later, we'll add, this is a pathophysiology, but we will definitely add the different types of heart failure. So as I've mentioned, your initial insult is your left ventricle function. So the responsibility of your left ventricle, if I may draw it here, this is the left side, right? So this is your left atria, this is your aortic valve, mitral valve here. So the left ventricle is responsible for ejection or ejecting blood into the systemic circulation, right? However, what we already mentioned, impaired LV function. So what are the reason why your LV function will impaired? Number one is when you become muscular, as in dilating or no, hypertrophic cardiomyopathy. Okay, so hypertrophic cardiomyopathy is an obstruction. You're creating an obstruction because there is that upper septum, it become really muscular. And when it contracts, when the ventricle contracts, okay, let's say you're gonna contract, so the size will decrease, right? Because it will contract this way. And every time you contract this way, you're pushing this septum forward. And when you're pushing this septum forward, you're creating an obstruction here into the aortic valve. And that's not good. So that's one thing, that if your heart, left side of the heart, keep experiencing this, it will eventually give up, right? So failure. The other one is the dilation. So when you have a dilating cardiomyopathy, this thing is so narrow and thin, and yet you have so much systolic volume that can go in. However, eventually it will just gonna keep dumping more fluids, or more blood, I should say, and that will create the S3. Okay, so ventricular gallop. So there is already some resistance in here because of the blood that's not being ejected, and yet you dump more blood because the atria will contract, right? And eventually your atria will be overcoming this pressure into the ventricle, and he will eventually become hypertrophied, and you develop S4, atrial gallop. All right, so Tennessee, Kentucky, key is the S3, Tennessee, ten is the S4. All right, so what's gonna happen? It's all about this low cardiac output and stroke volume. So again, renal perfusion decrease, releasing of RASS, right? Your renin, aldosterone, angiotensin, aldosterone system. And I think we discussed about that. So what does RAS, the renin, angiotensin, aldosterone, do to your body and even vasopressin? It will increase arterial blood pressure. Okay. It will increase arterial blood pressure. Not good. You don't want the high blood pressure. It will increase TPR, your total peripheral resistance, right? And then it also will gonna increase the ventricular filling pressure. Increase ventricular filling pressure. Would you imagine that? So it's not really good for your heart, right? And then it will also increase the sodium potassium imbalance. So what we call it will lead into increased volume overload. Okay, sodium potassium imbalance, and then it will also put a increased fluid or volume overload. Yeah, volume overload. Okay, and eventually your left ventricle will put a lot of stress. So increase LV wall stress. Okay, so that's what the RAS, renin, angiotensin, aldosterone system could do to your body, to your heart, especially to your left ventricle. So there is this what we call reflex arteriolar vasoconstriction. This is your increase your SVR because your TPR, total peripheral resistance, will go up, and this is what I was saying, and eventually increase afterload, and then continuously dilating, left ventricular dilatation. So that's what happened, guys. And the other neurohormonal response is the arginine or arginine vasopressin system. So this one. So that's why you see a vasopressin here. The arginine vasopressin system, or what we call AVP, is a potent vasoconstrictor that is normally inhibited by a stretch receptor into the atria, okay, during atrial distension. So probably over the course of this patient having a heart failure, we say they have life survival, time frame of 5 years. After 5 years, they get decompensated. Eventually, they die. And that's the statistics of heart failure. So in heart failure, these receptors become less sensitive. Your arginine vasopressin system, and there will be eventually decrease in inhibition, so they will produce more AVP. Not good, right? Because it's a potent vasoconstrictor. So that's something that we don't want. Increase in AVP activity will inhibit free water, so that means you're holding on water also. You will inhibit free water excretion, so you can't pee water anymore, like you're holding it. The higher your AVP, the higher it will retain fluids. So it will also impairs autoregulation over the years. So you're continuously increasing production of AVP, which is arginine, vasopressin system. Okay, so that is your arginine vasopressin system, potent vasoconstrictor. And then the other one is supposed to be the our friend in helping see congestive heart failure or heart failure patient is your ANP, atrial natriuretic peptide. So the atrial natriuretic peptide is a counter-regulatory hormones that opposes all these things to happen, opposes RAS to be released, ABP to be released, and what I mentioned a while ago, the the number one neurohormones is your adrenergic nervous system. So those three are adrenergic nervous system and RAS. And then the ABP. ANP is trying to stop that. However, the problem with ANP is produced in response to atrial distension. So if you become AFib, then you might not have ANP anymore, right? Or your ANP becomes less in chronic heart failure state. So what does ANP do? Atrial natriuretic peptide is responsible for decreasing the effect of angiotensin 1, right? And decreasing the release of aldosterone and vasopressin. And it will enhance renal excretion. So that's a good one, right? Decrease release of renin, aldosterone, I should say, and vasopressin. And then it will increase excretion, so you're gonna pee. But again, ANP, atrial natriuretic peptide, will disappear or slowly, help as the heart failure progress. Okay, so again, this is the stroke volume when you think about your Frank-Starling law. So the Frank-Starling law is what we always learn, that if you stretch the ventricle, a healthy ventricle will retract back or contract stronger. Okay. However, sometimes with our patients with heart failure, this is what happened. The low output symptoms and the congestive and low output symptoms. So this is where the normal curve is. Okay. So give them fluids, they will respond. However, sometimes they get really increased contractility in there. That's the normal response of the Frank-Starling law. But if they have a decreased contractility, this is where they're not fluid responsive, right? So we don't want to give them fluids, but we give them IV fluids here if the contractility increase. And if they have this issue and you give them more fluids, then they get congested. Not good. So you give them Lasix or nitroglycerin. So this is the symptoms, clinical presentation that you will see, right? So the right and the left. If the problem is the left, unable to contract well, there will be a forward failure, right? So what is a forward failure? Blame it to the low cardiac output. Your patient will start having a fatigue, so activity intolerance. Probably their EF will go down too, right? So they cannot tolerate. If you're trying to rush them to go to the, if they want to, use the commode, they will. It will might take time before they can get up and walk to the commode. So they can't. I mean, they're gonna have SOB, short of breath. They will have some syncopal episode and become dizzy. Then, of course, hypotension, decreased renal perfusion. They become renal failure, usually acute tubular necrosis, that will trigger symptoms of tachycardia, peripheral edema, not peeing anymore. So then, of course, what we just mentioned, your neurohormonal activation, your adrenergic stimulation system, your RAS, renin, angiotensin, aldosterone system, your AVP, right? Your and then your ANP, atrial natriuretic peptide, your arginine vasopressin system. And same thing, afterload will increase, it will deteriorate, it will make the left ventricle fail more because he needs to work hard with this resistance here. And then of course you have this venous pulling forward failure become worse. So this is where you see your patient probably anasarca, ascites, right? Everything here. So let's go back to the backward failure. So if this is a problem now, if the left ventricle is the problem now, it will backflow, right? So left atria will hypertrophied AFib, and then the lungs get flooded. So in the lungs, you have the hydrostatic pressure here, guys. Hydrostatic pressure is responsible for pushing fluid or water into the interstitial area. So therefore, you're gonna see an interstitial pulmonary edema first, okay? And then if continuously flooding, it goes to the alveoli, then alveoli pulmonary edema, alveolar pulmonary edema, and then it will go to the bronchial tree, right? So now you have a generalized pulmonary edema, bronchial edema. So you will see a pink frothy sputum. So bronchial edema. Too bad, right? Then the backward failure will go into the left or right ventricle. Eventually the right ventricle get muscular hypertrophy, right ventricular hypertrophy, right? So this was, I mentioned the S3, S4 a while ago, and we call it physiologic or functional MR, mitral regurgitation. Functional because it was caused by the pressure into the ventricle. So there will be a functional MR, mitral regurgitation, and tricuspid regurgitation, right? So I want you guys to think about that. Okay, so just looking at my notes in here, making sure that I did not miss anything. Alright guys, so what's gonna happen is into the right atria, there will be like a lot of pressure, backward flow, and the jugular vein will distend and the pressure will go up, okay? And your liver will have a backward failure also. So there will be an edema because it needs to empty. So supposed to be like blood goes in there, but because there's a pressure building up, it will go backflow. So there will be an ascites, there will be a symptoms of the GI, right? Because this is your tummy here. So it will continuously the portal hypertension here, right? This is the portal vein. Then of course nausea, vomiting, right? For your patient. And then the backward failure continues to the venous area, venous pooling here, so anasarca. Not good. And this is the typical patients that we see, right? Their legs are so swollen, their abdomen is so swollen, pretty much they're swollen, they're having short of breath, they're fatigued, they're syncopal and dizzy. So what do? You give them medication, right? You help them feel better. So the right and the left heart failure is a one way of thinking it. Sometimes it become a biventricular. Usually the culprit or the main source of the problem is the left. It starts with the left heart failure first, and then because of the backflow, it will cause pulmonary edema. I told you about the AFib. I told you about the alveolar interstitial pulmonary edema, alveolar edema, pulmonary edema, and bronchial edema that will cause dyspnea and cough. The problem also here, guys, is when they lie down, the more they will complain of orthopnea and paroxysmal nocturnal PND, dyspnea. Okay, so you'll see a lot of those. They will hyperventilate, they will be complaining of syncopal and dizzy. Okay, so when you connect them with PA pressure, you'll see a increased LB pressure, LA pressure, and PaOP wedge, and of course your PAP. So this is what we call pulmonary edema with cardiac involvement, because if you have an increased PaOP and you have an increased PAP, the heart causes the lungs to get sick also. And global heart failure when you have S3 and S4, and then it will go to the lungs, and then the lungs is not doing well, and now it's causing the right ventricle to fail. Okay, when the right ventricle to fail because of the lungs, then you see it will come out into the venous side, which your ascites, dependent edema, JVD, liver enlargement, just like what we discussed a while ago, nausea, vomiting, right? S3 and S4. Too bad. So the quality of life gets really, they suffer, they don't like, some patients don't like their experiencing. So what we're gonna do, so this is the stages of heart failure. Your stage 1, stage B, C, or D, right? So, or the New York Heart Association, the higher the number, so if you are on 4, patient with cardiac disease, inability to carry on physical activity, so this is, you have a lot of symptoms. All right, so this is pretty much like the moderate to severe cases. Okay, so what can we do? You have to make sure that we treat them, and one of the medications that we give is usually what we call the A, B, C, D, right? So the ABCD is A is ACE inhibitors, right? So you give them the ACE inhibitors to prevent ventricular remodeling. And sometimes you watch them for angioedema, right? B, beta blockers. Okay, so you're gonna give them beta blocker so that they can actually survive the mortality rate and let the heart relax a little bit, so you control the heart rate. And then C is there's a lot in C: calcium channel blocker, correct, those kind of things, right? And D is your diuretics, so diuretics, digoxin, things like that. And the advanced concept is equipment, meaning like heart, probably balloon pump, VAD, ventricular assistive device, yeah, and transplant, heart transplant. So therefore, we need to give their medication. So your Lasix, your beta blockers, your ACE inhibitors, your calcium channel blockers, your Coreg, things like that. Balloon pump as needed, intra-aortic balloon pump. That's your VAD also. You have to make sure that your patient will take all these medications on a regular basis, so that we can actually control the volume, increase in volume. We can actually control the contractility. We can actually control the congestion, things like that. So I'm hoping that this helps, because it's really imperative that we understand the management of heart failure. Thank you.